Good to see you in Norway, Professor John Gunderson.
It's very nice to be here.
Nice to hear. You're coming from McLean Hospital, Boston,
Yes.
United States. And you have been in this field always, haven't you?
Yes.
Yeah.
I started out, my first visit to Oslo was for a schizophrenia conference. And I fell in love with Oslo, but not so long after that, my studies on atypical schizophrenia took over, and that became borderline personality disorder.
Yes. So, and that was in the 1970s?
Yes.
Yes. What we are going to do today is to have a conversation on borderline personality disorder and your role in the development of the field, and possibly some speculations about the future. So, let's start with this. How is the borderline field, so to speak? By that I mean the patients, the therapists, the professional atmosphere, the modern understanding, as well as societal aspects. How is that now in these days compared to when you started in the 1970s?
When I started my training in psychiatry, which was in 1968, there was very little literature about borderline personality disorder per se. And the field of psychiatry was dominated by psychoanalysis in the training program I was in at Harvard. So there was this group of patients that didn't have a diagnosis, but which drove everybody crazy. And so we spent a lot of time talking about what to do with them, and for the most part, they were given psychotherapies from which they got worse. And that was the start of my interest in this group of patients. Even before I left residency training, I did the first effort to sort of describe who they were. And then a few years later, when I was working at the National Institute of Mental Health in the field of schizophrenia, this atypical schizophrenia thing was always on the margins. And
Yes, because borderline, the very notion or the known, it says something about at the border of something.
Yes, it was on the border of something. And
Yes.
Haga Kiskell famously said it's an adjective in search of a noun.
Yes.
And that the noun at that time was schizophrenia. So I had this opportunity, being a schizophrenia fellow, to try to identify who the people with atypical schizophrenia were. And that involved a literature review called Defining Borderline Patients, which was published in 1975. And that became the lead over the article, the cover article in the American Journal of Psychiatry. So all of a sudden, though all my studies were really schizophrenia, I became famous for defining borderline patients. Which was...
that was a lucky move then.
Well, it was a mixed blessing. When I moved to McLean Hospital in 1973, they wanted me to do grand rounds not on schizophrenia, but on borderline personality.
Grand rounds, that is lectures.
Yeah, the main lecture for the hospital community. Yes. And the room was filled. And I was still young and new to the hospital, and certainly didn't know much about borderline personality disorder, though this definition that I started at that time had...
So you were courageous then?
I wouldn't say so. I would say I had the only panic attack I've ever had in my life was when I got up in front of this group of people who looked to me to have expertise on a group of patients that I'd helped define, and the only reason I'd helped define them really was they scared me. It's a good obsessive compulsive mechanism to sort of distance yourself from a phenomena. I didn't really ever dream that this was something that I was going to. But then, you know,
this was to be your career.
Yes, I didn't imagine that. But I was running a schizophrenia unit at McLean Hospital, and all of a sudden, I didn't get any patients who were schizophrenic. I got all these patients who were...
At the border?
Yes, at the border. And then I did a more formal piece of research developed a structured interview and got comparison groups and then showed what were the discriminating characteristics of this. And that got published, and then it got accepted by the DSM-3, and it became an official classification in 1980.
That was a breakthrough, wasn't it?
Oh, major breakthrough, yes. It was sort of unexpected. I mean, the whole diagnosis was pretty new at that time. Otto Kernberg had popularized the idea that there were a large group of patients with borderline personality organization who, viewed through a psychoanalytic lens, could be responsive to long-term intensive psychoanalytic psychotherapies. And so within the psychoanalytic community, there was a lot of enthusiasm about treating these patients. And I was amongst those who was doing psychoanalytic training and hoped that by doing this, I would become one of those elite therapists who, by virtue of tolerance, patience,
yes,
and perseverance, would be able to treat borderline patients.
Yes, so that was a part of you, but another part was the empirical researcher. And what did the empirical researcher find?
Well, the empirical researcher, one of the first things I did was wonder where the successful cases were. Because I was in the process of studying psychotherapy with schizophrenic patients, and all my teachers had said this is what really great therapists can do. But I learned when I got close to the subject and talked to all the great teachers that they didn't treat schizophrenic patients. And here I was in a hospital where many people were doing treatments with borderline patients, but I didn't see very many successes. And when I looked at the literature, 54 books were written by psychoanalysts about the treatment of borderline patients. They didn't ever include successful case reports. What they chronicled was the difficulties they encountered. And it was, so that was a form of research. I started systematically looking for successful case reports and found 5. And when you looked at what the therapies were like, there was a lot more support in those therapies and a lot more direction in those therapies than the psychoanalytic model suggested.
Yes.
And it was sobering, and it also taught me what I was learning clinically, that it did not work to sort of be passive, and it did not work to sort of follow the patient's lead. You had to be active with these patients, and you had to be comfortable setting limits. It was not sufficient to say, I want to understand you. The patients viewed that with a certain amount of contempt. And
yes. But since that time, much have...
much has changed.
Much has changed. And it's the very conceptualization of what is the disorder about. You help to define the criteria.
Yes.
And also in the discussion of what are the underlying mechanisms, what are then the appropriate treatments, etc. So, how is the field today according to your view?
Well, you've identified two major arenas in which our thinking has changed: the understanding of the etiology or the causation of this disorder, and our understanding of what effective treatments constitute. And with respect to the first, back then it was entirely environmental. Was largely, the patients would tell us, you know, they have their problems because of their dysfunctional families. And often enough, the families did look dysfunctional, and that was sort of accepted. And the research, some of the original research into this showed that the disorder ran in families, which for the rest of psychiatry, that meant that there might be something genetic about it, but a lot of us simply interpreted that as, you know, the mother is a borderline, and that's an environmental causation. So it was a landmark discovery, finding, when your countryman, Sven Tergesen, in 2001, did the first twin study. He'd done a small twin study a long time before that, which was not very revealing, but 2001 he did the first significant twin study and identified a heritability of about 58%. And that was shocking. So much of the theorizing, so much of the clinical care based on those theories was on the idea that this was all a matter of the environment.
Yeah, so that became more acute, so to speak. You have to take in something about the biology, about the nature, and this heritability, and the kind of temperament disposition. What is that all about in your view?
Well, there's a couple strong candidates for it. One is what I would call interpersonal hypersensitivity. That is, that the child who goes on to develop borderline personality disorder is innately hypersensitive within their interpersonal interactions. And for instance, a mother who frowns is going to be seen as hostile or punitive, or a mother who leaves the room is going to cause alarm that they'll never come back, and that's more sustained and more acute in the children who develop this disorder. The second major hypothesis is that the predisposition has to do with problems with emotional control, so that it is not linked so much to adverse environment or especially interpersonal events as it is to a problem when there's adversity of a wide range of things. The child with a disposition for borderline personality disorder will have excessive, inappropriate emotional responses to that.
So that's some of the temperamental.
Yes. Those are the two main candidates.
Yes, yes. And then comes the attachment problems on top of that. And I think this hypersensitivity also makes the attachment process more difficult, perhaps, from the parent part.
Yes.
Of
This
you,
gives rise to a more complicated and sophisticated formulation in which it is not simply poor parenting, but that the poor parenting may in part be related to a child who is difficult, innately difficult. And so that the child with a genetic disposition for borderline personality disorder, whatever that is going to be difficult for parents. And you might take an unusual set of parents to provide the calm, stable, reflective environment which would lead that child away from developing this disorder into having a relatively normal outcome.
Yeah.
But a lot of parents who have vulnerabilities of their own those are vulnerabilities. Somebody's very anxious, somebody's very reactive, somebody's very irritable. Those are going to get exacerbated by a child like this, and they'll make the parenting worse.
Yes. And out of that comes problem with mentalizing.
Yes.
For the part of
attachment and mentalizing.
Yeah, for the part of the child. And if we add traumas, real traumas,
yes,
into that picture,
yes,
then we got a strong risk for borderline development.
Yes. It was worth noting historically that it was in the 1980s that our awareness of the role of trauma in the background of not just borderline patients, but many patients we became aware of it. We started then taking much more seriously patients' reports about having trauma in their childhoods. The psychoanalytic community, sadly, in retrospect, starting with Freud himself, had seen these as fantasies and not given them the credibility that they deserved. When that changed in the 1980s, the response was that people with borderline personality disorder, because 70% of them will report childhood trauma, really are the victims of trauma, and that to call this a personality disorder was an error, because it was actually re-victimizing them by suggesting that they had some accountability in the development of their disorder. And when you have a treatment which asks them to take responsibility for themselves, that was re-victimizing them. And it was a very difficult time for those of us who had developed the borderline personality disorder diagnosis. We became vilified ourselves. We were male for the most part, and we were blaming the victims. So it was that was another obstacle to the development of the disorder, its acceptance.
Yeah. And that was to put the question of trauma in its proper place.
Yes, it
not denying it, but not give it an extra weight either. Yes.
Yes, and that has taken time to do that.
Yes. So this points to the difficult question of the families of borderline patients, because some of these families are dysfunctional, some are not so dysfunctional.
Yes.
And you are known as a person who have been an advocate for integrating the family work within a total treatment system, to haven't you? It's
Oh, yeah.
the family aspect has preoccupied you. Can you tell a bit more about that part of it?
It was in the 1990s that I became impressed by just what the observation you made, that sometimes the families of borderline patients appear not to be so dysfunctional. And this was before the genetic evidence came in by Sven Gunderson. And it became clear to me that the families themselves are subjected to the same kind of problems that we clinicians lament and write many, many books about how difficult these patients are. But we're comfortable saying, well, the parents are the cause of it, rather than that the parents
are suffering the same.
Yeah, only they don't do it for a couple hours a week.
Yes.
You know, they have had a difficult family member for much of their lives. And of course, at that point, my kids are adolescents, and I'm wondering, you know, what kind of parental damage I've done, and that, you know, I'm much more identified now with the problems of the parents than I was as a younger man. And so we started doing multiple family groups in which a more compassionate view of parents was introduced. That is, they are suffering from the difficulties of a difficult child. And they turned out to be remarkably responsive to this. Rather than being these terrible people, it was clear that they all were doing the best they could. And sometimes, of course, what they were doing was damaging, but it was never willful. And for the most part, they were very grateful for the opportunity to talk about their problems, and were grateful for advice about how they might change. It was a startling contrast, in a way, with the previous view of the families that I had had, and a contrast with the views of the families which the patients themselves often presented. And it was gratifying to have parents who were so receptive to help, much more easy to work with than their sons and daughters.
And I think that perhaps this effort to integrate the parents and talk to the parents also paved the way for a more psychoeducational approach.
It did.
Yes.
Yes, it did. Yes. Now, you probably have gone through the same processes yourself.
Yes.
Right? You know. No, psychoeducation became a major part of what I and probably others started doing, where you talked with parents about the disorder, what the criteria meant, what the expected course was. Our models of etiology at that time were not as sophisticated as they are now, and as I outlined a few minutes ago, but they were good enough, that is, that there's some kind of disposition in the child which interacts and makes parenting difficult. And that was great comfort to them. And it sort of helped the patients and the parents step away from the parent blaming thing, as well as having the mental health field step away from parent blaming. It was a very positive step.
Yeah, and when you do practice this psychoeducational approach, then you have come quite a bit away from psychoanalysis, haven't you?
Oh yes. Oh yes, yes. No, and then it just progressed in my practice and in that of the programs that I oversee. It became more medicalized. That is, this is a serious psychiatric disorder, and that
yeah, could we talk a bit about that, because you are here in Norway also to talk about your model of good psychiatric management, and you have had a workshop yesterday.
Yes.
About this this topic. Could you explain it shortly, and then after we can discuss a bit this topic about medicalization?
Yeah. Good psychiatric management. I've been writing since 1984 books. Every 5 years or so, I update it about treatment of borderline personality disorder. And the books have always been meant to be sort of comprehensive about what's known about treatment, with my own clinical wisdom or experience woven into that. And I never saw myself as having a model of treatment per se, just sort of synthesizing and what's known and giving a broad overview which would be widely educational. It was something of a surprise then in 2009 when some Canadian colleagues did a big study on, they were primarily interested in demonstrating another demonstration of dialectical behavior therapy's usefulness in a broader sector of society. And they chose as a comparison group what they called general psychiatric management, which was sort of derived from these books I've been writing, the latest of which I'd written with the help of Paul Links, a Canadian colleague. So they condensed that into, and that was going to guide the comparison group. The remarkable thing was then that this general psychiatric management did as well as the dialectical behavior therapy. So all of a sudden, you know, there was maybe something else, you know, that I was not simply a generalist who is espousing general principles, or those general principles might be good enough for most patients without the additional training that DBT and other evidence-based treatments require. And so, a workshop yesterday here in Oslo. It's my mission in this last chapter of my career to tell the mental health professions that you don't have to be a specialist. You use good sense, and you can do well by most of these patients. And that's big news in a way, because most mental health professionals have concluded along the line that these patients are horrible to treat, and if you're going to do it, you better become a specialist with a whole lot of training, and that's the only way you can treat them, and that's never going to answer.
It's a lot of misconceptions in the field, taboos, old habits, myths going on, and here you come and say that, well, you can, if you do such and such and such and such in an ordinary, and it is not necessary to have it as a very special kind of making it more to the everyday
user friendly. It's called a generalist model, and one that can be taught within training programs. You know, you can't expect psychologists and psychiatrists to want to go through extensive training for borderline patients.
Well, you could.
Well, it's a lot to ask, because it takes up a large sector of the crowded curriculum and the competition for that time.
But it could be done, so I think that's a question. Is it a bit question about
That's interesting.
the culture of psychiatry in United States compared to Europe, Scandinavia, Northern Europe, Norway, and I'm a bit concerned when you stress this medicalization as a part of this model, and I wonder how much that reflects American psychiatry, American culture. American psychiatry is not in good shape these days. And the position of psychotherapy in the training of psychiatrists is not, as far as I have got it, is not highly prioritized.
Absolutely,
yes.
and I'm actually I shouldn't be surprised by what you're saying, but it's drawing my attention to something that I should have recognized more. That is that the psychotherapies remain a more central part of the training programs in Scandinavia in particular, but Europe maybe more generally than in the United States. In the United States, only about 15% of psychiatrists primarily do psychotherapy. And the rest of them
That's a shame.
primarily do psychopharmacology. And the training programs sometimes teach almost nothing about psychotherapy. And those that do, like the program that I'm involved with, is actually more enlightened than most of the, it's still got a very important role, but the training has often been psychodynamic therapies without much attention to empirically based treatments. Because the supervisory staff are from another generation.
Yes.
And there's been an effort to introduce cognitive behavioral paradigms, which are, again, it's hard for residents without a lot of time and effort and good supervision to acquire skills in one or the other, let alone both. In any event, you are right that it may well be a United States phenomena that more so than the rest of the world, or certainly this part of the world, that my advocacy appeals to. That is, I'm fighting an uphill struggle in the United States. Interestingly, since I've started doing this, it's been found to be very appealing because most
Good to hear.
Most residency programs are now trying to redress the balance, as there are many reasons for that. But one of the appeals of going into our field has always been the stories that patients tell. Listening to patients is the primary source of satisfaction for psychiatrists.
And partake in it, as it is enacted in the here and now.
And then to become a participant in the process of active listening and introducing change is still a very exciting, maybe the most exciting appeal of psychiatry. But as it's gotten pushed further and further towards a biological-only paradigm, there has been a backlash against that. And partly due to the appeals that residents themselves make, they want to learn psychotherapies, partly due to the fact that the high hopes from biological treatments have now been put more in perspective. They are the whole ideal that there are specific chemical imbalances for specific illnesses is really not held up.
To the contrary.
To the contrary.
It seems that it creates more problems than, yes. So,
and the effectiveness of medications is much less than advertised.
Yes.
And that when you...
And you know, this is a big concern. There is the debate now going on the role of psychiatry in the aftermath of the book of Alan Francis, the Guts book, the books on the question about inequality. This is the borderline problems are also linked to the degree of inequality in a society. It is something which is related to poverty, bad parental conditions, bad schooling, etc., which is reflected in attachment problems, in learning difficulties, criminality, etc., etc., and takes root in the personality. All these things are linked together, and I think it's a growing awareness of it.
And from my point of view, thank heavens.
Yes, yes, for me too. Could we come back a bit to the gender question, since the evidence of the effectiveness of the psychotherapies for borderline patients seems to be valid for females.
Yes.
Yes. 85% of the patients in the studies, they are females.
Yes.
Yeah. We actually don't know so much about men and how they respond. And the clinic you have in Boston, that's only for females, isn't it?
We have two programs.
Mm-hmm.
One is a residential program where people stay overnight, and that's for females only. Our outpatient clinic, it's an IOP, intensive outpatient program, that's for males and females.
So there you integrate men?
Yes.
Yes.
And well, this is an interesting story. One of the males treated in our outpatient program is a famous football player, Brandon Marshall. And shortly after he left our program, he went public with the idea that he had borderline personality disorder and his life had been changed by the treatment he received.
Did he become a better football player?
He was an all-star before his treatment, and he's been an all-star since his treatment. The big difference is that he hasn't had any major problems with within his relationships that made the newspapers, and that were so disruptive to his teams. So, but he's the first public figure that has ever gone, to my knowledge, public about having the diagnosis. And he put a male face on an otherwise largely female disorder.
Yeah.
And the result...
And how come that it is a predominantly female
Well, I had a great theory about this, but I now have to abandon it. No, I thought, well, it's predominantly female because little girls are inherently more affiliative, and little boys are more inherently, I can't remember what the word was, but mechanistic. You know, they like playing with hard toys instead of soft toys, and they don't cling as much to their caretakers. And so I thought that was a good paradigm, because this is a disorder that really has to do with that attachment and the problems of finding comfort in relationships with caretakers. Well, that made sense. So when the first reports came out about there being an equal number of males, I simply thought, well, this is a methodological error.
Yes. You are thinking about the epidemiological studies.
Yes. That's where it came to our attention.
In the community, there is no gender problems.
That's
but
right.
in the treatment services, there is a large gender difference, yes.
So I'm afraid I have to give up that very appealing theory, but the fact is that there are just as many males as there are females when you get out in the community. They still, well, Brandon Marshall's influence for us locally has been that we now see more male clients, patients, than we used to. They're still a minority. And we're going to open a program this year for male borderline patients only.
Mm-hmm.
And so it's that is, talk about the future, I see that as one of the things which will happen in the future, is that more males with this, the diagnosis will be given more readily to males, and males will be more likely to seek treatment for it. But I think most of the males have ended up in substance abuse programs.
Yes.
Or in the forensic area.
Yes. So you have to have some strategy for dealing with the drug problem and the antisocial problem with when you take in those males.
But there are significant comorbidities for females also, but they get less emphasized if someone's female, and they get exaggerated if one's male. And that's just the way it's been.
We are approaching the end. It's in your lifelong career, dealing with these borderline problems, deep existential problems, how society contributes to identity disturbances, etc. What's the rewarding thing about it?
It's a hard question to answer with any confidence. I know that somewhere around 20 years ago, 25 years ago, I felt like the level of intimacy that borderline patients required of me was greater than I had elsewhere in my life. They required that I listen to things which I would not have heard or would not have wanted to hear. And like the Grinch, my heart grew a bit larger because of this. And certainly my tolerance for and interest in understanding people who appear to be so offensive and demanding changed as a result of my work with them. Now that might have happened anyway. You know, we all grow up. And there are some people who have those qualities without ever treating borderline patients. So I can't say for sure, but I think that it's made me a more benevolent person.
Yes, and perhaps more vital, since I agree with you, since borderline patients, they demand your presence You can't be absent and sleep, and you have to be there. You have to be vigilant, present.
Absolutely.
And so you have to keep alive, stay alive.
Right there. And
yes.
if you blink your eyes, they'll notice it. Yes.
Yeah. Okay. Thank you very much, Professor John Gunderson, for this conversation on the topic of borderline personality disorder.
Thank you, Professor Sigmund.